Today, let us take a look at psoriasis. Psoriasis is a fairly common skin condition which affects 3 to 4% of the world population. This is the outline of the talk today. We will look at the definition of what psoriasis is, pathophysiology, types of psoriasis, joint involvement, nail changes, as well as comorbidities before we look at treatment, and finally a summary in the form of a cheat sheet. Psoriasis is defined as a chronic disorder with polygenic predisposition and triggering environmental factors. For example, bacterial infection, trauma, and drugs. This is the pathophysiology of psoriasis. First, skin injury in normal skin leads to the release of LL37 RNA and DNA, and LL37 DNA and LL37 RNA complexes bind to the toll-like receptors. This leads to activation of the dendritic cells with involvement of interferon gamma. The antigen is presented to autoreactive T cells, and then you get expansion and differentiation of the Th cells. And you can note here that the cytokines involved are interleukin-23, TNF-alpha, and interleukin-12. And then the cells involved are Th22, Th17, and Th1. And further to that, you get more release of cytokines, including interleukin-22, interleukin-17, TNF-alpha, interferon gamma. And this all leads to keratinocyte activation, which then causes proliferation of your keratinocytes, skin thickening and erythema, vasodilatation, angiogenesis, and there is a positive feedback loop. Besides that, at the top, you can see there's also the role of PLA2G4D generated lipid autoantigens activating your T cells, as well as ADAM-TSL5 autoantigen activating your CD8 T cells, and this also contributes to your interleukin-17A, interleukin-22, and interferon gamma release, which also contributes to your keratinocyte activation. Triggers of psoriasis include genetic factors, stress, infections, injury, which is also known as Koebner phenomenon, where your psoriatic plaques will emerge at areas of injury or trauma. Next, it can also be triggered by hormones, drugs, sunlight, obesity, alcohol, and smoking. The most common type of psoriasis is known as chronic plaque psoriasis, and this is the prototype of the disease whenever most of us think of psoriasis. So in this type of psoriasis, you have sharply marginated, which means well-defined, erythematous papules or plaques with silvery white scales. These can coalesce to form polycyclic or serpiginous patterns. Common sites involved include the elbows, knees, sacrogluteal region, scalp, palms and soles, and it can even be generalized. Auspitz sign occurs if you remove the scale and you see minute blood droplets. However, we don't recommend that you do this routinely in clinical practice anymore. The next type of psoriasis is acute guttate psoriasis. And here, it is often seen in young people, and they present with small salmon pink papules with or without scaling. This often affects the trunk, face, and scalp, and it is associated with streptococcal infection. Next, we do see this quite often in clinic as well. This is inverse, or also known as flexural psoriasis, in which patients come with smooth, well-defined patches in the body folds. Pustular psoriasis comes in two forms. It can be generalized, in which you get the pustules, which coalesce to form legs of pus, or it can be localized to palms and soles. Erythrodermic psoriasis is a severe form of psoriasis affecting the entire skin surface, and you can see that it's redness and there's scaling affecting most of this patient's body surface area. This is a picture of scalp psoriasis, and you can appreciate in scalp psoriasis, the plaques and the involvement tends to extend beyond the hairline. Joint involvement comes in 5 patterns. Distal arthritis involving your DIP joints, distal interphalangeal joints, also easily remembered as OA or osteoarthritis-like. Next, oligoarthritis, symmetric polyarthritis resembling rheumatoid arthritis or RA-like, arthritis mutilans, which results in a pencil in cup deformity, as well as spondyloarthropathy, which is an ankylosing spondylitis-like subtype of the joint involvement. There are a variety of nail changes in psoriasis. Examples are pitting, onycholysis, yellowing, also known as the oil spot or the salmon patch sign, ridging, subangular hyperkeratosis, as well as splinter hemorrhages. Here are some examples. On the left, you can see nail pitting. In the middle, salmon patch with onycholysis, as well as some pitting. And on the right, you can appreciate subangular hyperkeratosis. Psoriasis can also lead to a range of comorbidities involving the eye, such as uveitis, COPD, pulmonary arterial hypertension, pneumonia, fatty liver, diabetes, pancreatitis, avascular necrosis, and osteoporosis. A lot of neurological or mental health disorders such as stroke, depression, anxiety, schizophrenia, Parkinsonism, asthma, hypertension, aortic aneurysm, coronary artery disease, arrhythmias, peptic ulcers, chronic kidney disease, which can become end-stage, inflammatory bowel disease, and psoriatic arthritis, which we have mentioned earlier. But of note, the most important thing to remember is that psoriasis is linked with metabolic syndrome or metabolic comorbidities. In terms of treatment, this algorithm is based on the Malaysian Clinical Practice Guidelines for Psoriasis vulgaris, and we can divide it into mild, moderate, or severe. Bear in mind that these cutoff scores are only applicable in Malaysia, and do note other cutoff scores will be applicable according to other countries' practice guidelines. So for mild, this is defined in our guidelines as body surface area less than 10%, okay, equals or less to 10%, or PASI score, which is psoriasis area and severity index, 10 or less. And this mainly you use topical therapy. For moderate disease, and in Malaysia, this is defined as body surface area between 10 to 20% or PASI score of 10 to 20, you assess the Dermatology Life Quality Index. If it is 10 or less, you can use topical therapy. 10 or more, more than 10, then you will need to go to the pathway for more severe disease. In severe disease, this is defined as body surface area more than 30% or a PASI score of more than 20. So if you have phototherapy available in your center, you can consider phototherapy. And this can also be used as a pathway for patients with moderate disease, but with severe impairment of your quality of life based on your DLQI. However, if phototherapy is failed, contraindicated, or not available, then you would need to think of other options, including systemic therapies such as methotrexate, which is first line, acitretin, or short-term cyclosporine, as well as a newer option known as apremilast. If these conventional systemics do not work or patient is intolerant to them, then you would have to consider biologics. Now, on the other hand, for mild to moderate disease, the mainstay of treatment remains to be topical therapy, and options include tar. Ditranol is sometimes used for large plaque, but we hardly use that anymore. Topical corticosteroids are often used and mostly for short-term therapy. You can also consider topical vitamin D analogs less than 100 grams per week, and topical calcineurin inhibitors, especially for the face and flexures where you have thinner skin. So in moderate to severe disease, topical treatment options should also be used, but you would also need to refer to the pathway on the right for more effective treatment. Common biologics available are TNF inhibitors such as adalimumab, etanercept, infliximab, and certolizumab. Interleukin-12 and 23 inhibitor known as ustekinumab, interleukin-17 inhibitors are secukinumab, izakizumab, and brodalumab, and interleukin-23 inhibitors such as guselkumab, risankizumab, and tildrakizumab. Of note, certolizumab can be used in pregnancy. So this is a summary or a cheat sheet for you for examination purposes. So types of psoriasis, there are 5 types, the most common being chronic plaque psoriasis, but you also have gutted psoriasis, inverse flexural psoriasis, pustular psoriasis, and erythrodermic psoriasis. Next, types of psoriatic arthritis: distal arthritis involving your distal interphalangeal joints, oligoarthritis, symmetric polyarthritis resembling rheumatoid arthritis, arthritis mutilans, as well as spondyloarthropathy. And lastly, for nail involvement, you have pitting, onycholysis, yellowing or all spot sign, ridging, subungual hyperkeratosis, as well as splinter hemorrhages. So that's all from me today about psoriasis, and feel free to tune in for more dermatology information on Derm School. Thank you for your attention.